Hello, my name is Fiona Costello. I am a neurologist and a neuro-ophthalmologist at the University of Calgary. So, for those of you maybe unfamiliar with what a neuro-ophthalmologist does, I'll say that much of my practice is really focused on, pun intended, the study of how the visual system, namely how the eyes see and how the eyes move, is related to disorders of the central nervous system, so that's the brain and spinal cord, but also the peripheral nervous system. So my involvement in the care of patients with neuromyelitis optica is really often as the first person who sees someone coming in with an event of optic neuritis that may be initially assumed, for example, to be related to multiple sclerosis, but is in fact related, or the first presentation of neuromyelitis optica. I also see patients, am I starting too early, Sumaira?
No, you're totally fine.
Okay, I'll just keep talking.
Yeah, go ahead.
Yeah. My other involvement really is as a neurologist. So when I'm wearing my hat on the wards, for example, or in a general neurology setting, I'll see patients come in with non-visual things, for example, such as transverse myelitis or intractable hiccups, although often they take a little bit of time to get to me if hiccups are the presenting problems. So I follow many neuromyelitis optica patients because I look to see how their vision is faring through the course of their illness. And obviously, they're very nervous if their presentation was such that they lost vision in one eye or both eyes, and they want to hold on to what they have. So I work very closely with other colleagues as part of a multidisciplinary team to look after patients with neuromyelitis optica spectrum disorder manifestations. So I want to thank you for having me. I guess I'm part of the webinar series being held by the Sumaira Foundation and sponsored by Alexion Pharmaceuticals. So I want to talk to you today about neuromyelitis optica and optic neuritis, or optic neuritis in neuromyelitis optica spectrum disorder. And it's really part of the overarching series of webinars, Understanding the Canadian Journey. So I thought what I would do is maybe break the ice a little bit and present a few slides. Not that I'm married to my slides, but I think that maybe we'll get the conversation started. And then we can have a question and answer session. So you can shoot me any questions you have through the Q&A, and I will do my best or through the chat to answer them. I can't promise that I'll be able to answer them all well, but I'll do my best. And this is all going to be recorded as part of the Sumaira Foundation YouTube sort of a process. So without further ado, I will share my screen and show you the madness that is my desktop. And what we'll do is get going. So I'll say slideshow from the start. So neuromyelitis optica spectrum disorder and NMO, I'll use these terms somewhat interchangeably. And I'm under-caffeinated, so I might trip up over my words a bit. But NMO and optic neuritis, how do we understand this journey together? So full disclosure, I have received consultancy fees from Alexion, Frequency Therapeutics, and Roche. But my real confession is just as described. I'm a neuro-ophthalmologist, so I love the visual system. I love interpreting all matters of the central nervous system and the peripheral nervous system through the visual system. So I'm very biased towards trying to see what the eyes can teach us. And I hope by the end of this discussion and this time we have together, you'll all appreciate how much I value vision, and no doubt you do the same. So I thought basically we could talk together about what optic neuritis is as a concept and review the link between NMO and optic neuritis. And in so doing, perhaps describe a potential role for a neuro-ophthalmologist, or if one is not available to you, perhaps an ophthalmologist paired with a neurologist could offer in the care of people who live with neuromyelitis optica spectrum disorder. So let's take a 10,000-foot view. So optic neuritis actually refers to any infectious or inflammatory process of the optic nerve. And I liken the optic nerve as a USB cable. I'm borrowing that from one of my one of my residents, actually, Michael Mack. I really like the analogy. The USB cable behind the eye is a little bit like a ponytail, kind of behind my head. It gathers all the retinal fibers and it carries them along the visual pathway to what is actually the visual processing center in the brain back here. So while optic neuritis is something that I see in various conditions, such as lupus, if it's a systemic disorder, or in infections such as tuberculosis, or even paraneoplastic. So by that I mean cancers that present with optic nerve involvement. The most common setting for me, at least, where I see optic neuritis manifest is in central nervous system inflammatory disorders. And certainly by far, multiple sclerosis would be the most common thing I see in concert with optic neuritis. And I think that's why a lot of patients with NMO initially may get mistaken for having multiple sclerosis. But there are specific features that help us identify optic neuritis patients who have NMO. So it starts with, who is your typical patient? So way back in 1992, perhaps before some of you were born, a study was done on, it was published in the New England Journal of Medicine, and it's a fairly pivotal study in my field, neuro-ophthalmology, called the Optic Neuritis Treatment Trial. And we learned a lot about the presenting features of more typical optic neuritis, namely optic neuritis that is the first manifestation of people who eventually go on to develop a diagnosis of multiple sclerosis. But our typical patient with optic neuritis in the optic neuritis treatment trial is actually not our typical neuromyelitis optica spectrum disorder patient. So in the optic neuritis treatment trial, 77% of patients were female. So that's a common theme. Certainly in NMO, most patients are also female. But the average age of optic neuritis in the optic neuritis treatment trial was about 31.8 years. And believe it or not, the average age for an NMO diagnosis is closer to 40. The male to female ratio for optic neuritis and MS is anywhere from 2 to 3 women for each man, whereas it's much higher in NMO, as many of you know, with a ratio as high to 9 to 1, favoring females. And depending on where you live, you may be more predisposed to NMO than MS. So the prevalence of neuromyelitis optica spectrum disorder in the United States is 3.9 per 100,000, but it actually can be as high as 10 per 100,000 in populations of people who are non-white, so particularly those of African descent. And that's really important because in the optic neuritis treatment trial, 85% of the people presenting in that study were Caucasian in terms of their ethnicity. So it's really important, and one message that I try my best to impart to my ophthalmology colleagues and the residents that I work with is not to take all the lessons from the optic neuritis treatment trial and assume they apply to all comers with optic neuritis, particularly those with NMO, because you really cannot let optic neuritis in a patient presenting with NMO go untreated, because there's a pretty high probability or chance that they're going to be left with some vision loss. So in typical optic neuritis, and I'll use that phrase sort of, generically to refer to the optic neuritis, most of the people that I work with, people who are neuro-ophthalmologists like me, the typical optic neuritis patient who may or may not go on to get multiple sclerosis will report pain a lot of the time. And that is pain with eye movements often. So, it starts off with like a little bit of a sense of blur and ache. Pain is not necessarily dramatic, but it's there. It may not even be as bad as some headaches that the person who's having this symptom experiences. But pain may not be as common in patients presenting with NMO, and optic neuritis being their heralding finding. So I find that an important red flag. Although 8 to 10% of typical optic neuritis patients won't have pain, when I don't hear that history of pain, it does make me wonder, could I be only dealing with an atypical optic neuritis? And could that atypical optic neuritis be the first presentation of neuromyelitis optica? So visual acuity, and I'm sure many of you listening to this have had your vision checked. So, we throw up a really black colored E on a really white background. And we ask people to read down, the chart to the smallest line of print they can see. And for most of us, that's 20/20. But patients with optic neuritis of any kind will often have loss of their ability to read some of the smaller letters on the chart. But one thing about patients with NMO is they tend to come in with quite severe vision loss. And so that's another hint to me that I might be dealing with an atypical optic neuritis. So instead of being 20/80, instead of being 20/100, seeing at 20 feet what they should see at 100, these are people who may not even be able to see this big E, and this is, the 2400 line. So severe vision loss is something that I look for, but I have to admit, I do see severe vision loss in all comers with optic neuritis, but it does get my attention. More importantly, if I'm looking at that person sort of at, week 3 from the onset of their symptoms, namely pain, and there's been no recovery or improvement, I start to worry about an atypical optic neuritis subtype, and definitely neuromyelitis optica is on that list. So if recovery is not beginning at the sort of 3 to 4 week mark, my spidey senses start tingling. So there's lots of visual testing we use in multiple sclerosis, and it's equally applicable to people who have NMO. So we look at high contrast letter acuity. So that's the really, black colored letters on the white background. We have low contrast visual acuity where it's sort of like 50 shades of gray. You have a lighter colored letter on a different background. We use MRI scan imaging of the orbits, and here you see the optic nerve. And just like I told you, the optic nerve is enhanced here, but it's this sort of a USB cable that leaves the optic nerve here and kind of travels all the way back to a crossover area called the chiasm. We use color vision testing, we use visual field testing, and we look at the back of the eye. So many patients with optic neuritis have color vision loss, and they may not be aware of it. So what happens is somebody will come into my clinic and they have vision loss in their eye. If it's mild, and admittedly, that's often not the case in someone who has NMO, they, are looking at the world through a binocular view. So the brain sees what the best eye perceives. And it's only when I get them to cover their good eye and they go to look at something that is colorful, be it a red target or here, color plates, they go, wow, like I didn't realize I really can't see those colors at all, even though those shapes are pretty big. So this is a really helpful hint to me in someone presenting with pain. They have changes in terms of on the examination of how their pupil reacts. I can tell their central vision is down when I go to have them read the eye chart. And then their color vision may be disproportionately bad. So even if they can read sort of from the 20/50 line, which is sort of, mild to moderate vision loss, they can't see any of these colored shapes on the plates. That's a hint to me of an optic nerve problem. And in the right setting, it's an optic neuritis. So we've learned again from the optic neuritis treatment trial that patients with inflammation of the optic nerve, so of that USB cable, can present with a variety of visual field defects. And so by far, the most dreaded test that I put people through in the neuro-ophthalmology clinic is the visual field. And so for those of you who've done it, it's that clicker test where you have to look with one eye and indicate when you see the light. And people hate it because they always feel like they're failing. They feel exhausted by it. They're not sure if they saw the light or not. It's not easy, but it gives us really important roadmap information as to how the optic nerve has been affected and what part of the optic nerve might be inflamed in the setting of optic neuritis. So here you see a area of black where the person cannot see from something we call the physiological blind spot. So that's just where the optic nerve inserts into the back of the eye. And this person with this visual field would look right at you and maybe not be able to see some of your facial features, but could see your hair and things around you. So this would be a central visual field defect that is certainly common in patients with NMO, but is also common in people who have optic neuritis from different causes. And it really reflects that these feeder fibers from the retina that give rise to the optic nerve, and we're looking at the optic nerve here as it is about to exit the back of the eye, kind of front on. This implicates these fibers here coming from the macula called the papillomacular bundle. But many patients with NMO will actually have what we call an altitudinal defect. So they'll have, for example, fibers in the upper part of the retina that give rise to the top part of the nerve, causing them an altitudinal defect, meaning they'll say, there's this spot in the center part of my vision, but I really can't see anything kind of below my nose. And we've learned from following people who have NMO and from actually the criteria published for this diagnosis in 2015 that altitudinal defects, namely those where it's almost like there's a cutoff point below which you can't see or above which you can't see, these can be features that we look for on this visual field test for people who may have NMO. So when your doctor makes you do this test you hate, please forgive them. I ask my patients to forgive me for the very same reason, because it does give us really good information, more arguably than just reading the really black letters off the really white background. So what about the back of the eye? That's called a fundus examination. This is the view that I see of my patients when I look through the pupil. So when your doc's coming in with that scope and you're worried about pre-COVID, before their mask, what they might have been eating for lunch, valid concern. What we're looking at is through the pupil, we can actually see this very back area of the retina. And it's quite fascinating because the back of the eye is the front of the brain. And so this is the view that we get of the optic nerve. And it's like looking down, the front of a garden hose, because we're looking at it front on and it leaves the eye sort of, as I mentioned, like a ponytail would leave your head. So these big vessels are the veins and the smaller vessels are the arteries, and all around is the retina. And over the top of the retina is almost like this Vaseline layer where all of the, what we call axons, or the nerve fibers from the ganglion cells, which are deeper in the retina, are carried, and they all exit the eye through the optic nerve. So often with a person who has optic neuritis, they may present, for example, to an optometrist or to an ophthalmologist, and that individual is looking around to make sure, like, are there any retinal detachments? Do I see any blood clots, or do I see any bleeding in the retina? When they look at the back of the eye, the mantra for optic neuritis is that the patient sees nothing, but the doctor sees nothing also. Because the problem is not necessarily here in the front part of the optic nerve, it's actually behind the eye. So on day 0, when you present to your eye care doctor, one of the features that gets their attention is actually a fairly normal looking, fundus exam. Now, depending on the kind of optic neuritis you have, and some people have something called myelin oligodendrocyte glycoprotein associated disease, MOG optic neuritis tends to be a little different because those patients can have a lot of upfront swelling. So their nerve won't look as crisp in terms of around its contours as this. It'll be actually swollen. And that reflects that the inflammation involves the optic nerve head, so where it joins the back of the eye, as opposed to the case for many patients who have NMO, where the injury is actually further behind the eye in what we call the intracranial part of the optic nerve. So for those of you who had optic neuritis, you probably received high-dose corticosteroids, and depending on perhaps whether you were treated in an outpatient setting or an inpatient setting, you may have gotten 1,000 milligrams of IV solumedrol. So that was a treatment dose that was actually learned from the optic neuritis treatment trial. But some folks will also have gotten an oral equivalent. So we've learned in studies since the optic neuritis treatment trial that was published in 1992 that if you give a high dose oral load of steroids, so we'll often give here at the University of Calgary 1,250 milligrams of prednisone, which is equivalent in terms of what we call its bioavailability, so what your body gets from that, to the 1,000 milligrams of solumedrol, you might have gotten a high oral load, or you might have gotten a high IV load of steroids, typically for 3 to 5 days. And then if your doc was really worried about neuromyelitis optica, they might have slowly tapered you, and you probably didn't feel great on that medication. It may or may not have helped your vision. It may or may not have helped any pain you had, but it has side effects. So a lot of people who take steroids have sleeplessness, and emotionally they feel a little bit up and down. They can get headaches and jittery. And on the long haul, it can definitely give people side effects. When patients have really severe optic neuritis, their doctor may or may not stop with steroids, and they may move on to something called plasma exchange. So that's when you get a big kind of catheter put in a vein, and we sort of wash the blood to try and make a difference in terms of the visual outcome. And once a diagnosis of NMO is established, I think many doctors, including myself, are a little bit quicker to move to this plasma exchange, and it would require an admission to hospital. But admittedly, when we're not sure what kind of optic neuritis a patient has, they might not get that right out of the gates. And I'd be curious to hear from any of you what your experiences maybe been. So you might be saying sort of, why the eye? Well, I did admit that I'm obviously biased towards the eye, but I've hinted a little bit. You know, we know that the eye at the very back is the very front of the brain, and we can learn a lot about conditions like neuromyelitis optica through its effects on the eye or the visual system. And that's really what makes vision one of the core kind of features that doctors focus on in terms of trying to figure this diagnosis out. So severe optic neuritis, often with kind of the acuity or the ability to read the chart that's worse than 2200, with visual field loss, so the roadmap to that central and peripheral vision problem where people can't see centrally or they can't see up or down, and what's called an altitudinal defect. And then sometimes a pretty unremarkable examination, so the patient can't see and the doctor can't see much either. These are all features of optic neuritis that I weigh in the balance when I'm trying to figure out, hey, is this person presenting with optic neuritis that's going to get better by itself largely, that may or may not be linked to multiple sclerosis, and I can simply kind of watch and wait and worry a little bit less? Or are there enough red flags in this that I should be really worried about this person maybe having their very first clinical presentation of neuromyelitis optica? So for me, some of that is patient related. I've kind of again talked about this, but I'll just highlight it and reiterate it. So who do I worry about having NMO? Firstly, I worry about somebody who is largely not in the optic neuritis treatment trial. So someone of non-white ethnicity, although I do have patients who are Caucasian who have NMO. I worry about someone who's a little bit older than the average age of optic neuritis in the optic neuritis treatment trial, where the average age was 31.8 years. I look for an age that's closer to 40. However, I have plenty of NMO patients who are quite young. I look for severe presentation. So I look for really bad vision at presentation with or without pain. And the absence of pain will definitely get my attention. I look at poor recovery. So it's week 3 and they tell me that they've had this presentation and they really haven't had much improvement in that time frame, or it's at the month mark and there's no improvement. That really worries me. And then I can use some additional tests in addition to a few, but not, I'm sure I've missed a few things. Those are, you know, some of the things about the patient and the initial findings on the examination that worry me. But there are additional tools sort of at the disposal of a neuro-ophthalmologist, an ophthalmologist, or a neurologist involved in your care. So as I mentioned, like, the visual system is quite fascinating in that the vast majority of sensory information that our brain receives actually comes through the visual system. And it starts with those USB cables you see right here that leave the back of the eye and carry information to the visual processing centers of the brain. So one thing about the visual system is that it really will bring patients with NMO to doctors' attention. There's this old saying in medicine that patients present to the doctor when they can't pee or they can't see. So I think in my own experience, and this may be different from some of you on the call, but I'd be curious. I've had patients who had hiccups, for example, for 3 weeks, but they either didn't present for care, or when they did, it was to like a specialist in a different kind of area of medicine. And they may or may not have been recognized as having NMO. But the visual system is something that when you go to an eye care doctor and a person has some of those things I've talked about, they're not your typical person with typical optic neuritis, they've shown poor recovery, this will, I think, often quickly register in a doctor's mind, hey, this is a person I really need to be cautious with. So I think the visual system has specific merits because it can be a little bit more specific in helping us recognize the diagnosis of NMO than some other clinical presentations that maybe can closely overlap with other conditions such as MS. We also have lots of really kind of cool tools at our disposal in ophthalmology and neuro-ophthalmology where we can look in the back of the eye, not just eyeballing the optic nerve in the way that I showed you, but actually being able to measure through this schematic layers of the retina that will tell us that a person's optic neuritis is perhaps a little more severe than typical. And that will also make us consider NMO as a diagnosis. So through something called OCT, and that's just a light study that it's an imaging technology that allows us in a non-painful, non-invasive way to measure things in the back of the eye that give us a marker of how severe an optic nerve injury behind the eye has caused sort of a backward sort of thinning of wires within the nerve that thin the retina. We get an in vivo kind of optical biopsy, not a literal biopsy, but a biopsy of optic nerve integrity. And this is an example of a person who has NMO, and they have evidence of this like white band here in their spinal cord. So that's a longitudinal extensive transverse myelitis lesion. Admittedly, this is a little bit more robust image than this picture right here of the optic nerves. But with OCT, we bounce light waves off the back of the eye and we get an indirect measure of the thickness around the optic nerve. And you can see that in this nerve, it looks really white and the measurements have fallen in the red zone. And that's like a cookie cutter around the nerve. And then it's averaged out, like you pulled out, you know, kind of the retina and like laid it out in this little algorithm, what you see here, where our fibers are thicker, usually superiorly and inferiorly than they are here temporally and nasally, or I should say temporally is here. But all the measurements here are in the red zone, so they're quite thin. So people who have optic neuritis with a diagnosis of NMO often have really quite severe optic nerve injury. So they'll have a lot more thinning than patients who have optic neuritis from other causes. And then we look at the myelin signal. So right here behind the eye, and this is again the optic nerve, and this is like a side view of the eye. This is where the optic nerve gets its insulation or its myelin. And so we can measure with things like visual evoked potential. So any of you who had that test where you had to look at sometimes a checkerboard and these electrical leads messed up your hair, and your doctor was looking at how quickly information travels from here to here along the optic nerve, it really reflects how information travels the whole way along the visual system. But that can give us a sense of how much damage to the myelin or insulation around the nerve has occurred with what's called a delayed visual evoked potential response. And these are all things that we can do to kind of understand how much of the injury is like a insulation injury around the nerve, and then how much of the injury is, you know, to the nerve itself in terms of the thickness of indirect measures of the nerve caliber in the retina. And I do that with visual evoked potential testing and OCT testing kind of respectively. And then I don't know how many times your docs have shown you MRI scans. I try my best because I realize I blather on a lot. I probably, despite my best efforts, sound like I'm from the planet Vulcan all the time with the jargon terms. And I think for my patients, the people that I look after, I think of patients as a term of endearment. I think a picture says a lot more. And so these are nice pictures. And again, just to orient you, this is the eye here. This is actually a right eye. It looks like the left side of the picture. This is where the nose would be. This is what looking down, like if we were looking at a peephole, kind of through the person's head, you know, we were looking down at with the way that the nerve exits the back of the eye, you see it kind of comes back here in what we call the chiasm. All this sort of area of brighter signal is where the nerve is unhappy and it's inflamed. And what we know is that for people who have NMO, more than 50% of their sort of anterior visual system, so that's like they're part of the visual system that kind of starts from here and goes to the eye, that will be involved. And unlike, say, MOG optic neuritis, which really likes to involve the optic nerve here, right where it meets the eye, in NMO, that signal extends right back and it's a little bit more posterior. So kind of coming back to the Canadian journey, I think one thing that separates my sort of clinical experience from some of my American colleagues is I don't really get to get these MRI features right away. Like, I'll have to haggle hard to get MRI scans for my patients, even if they have NMO. I wish it wasn't the case, but it definitely is. And it might take me, for example, several weeks to get this study. It's easier if the person's admitted to hospital, and I think that's sometimes why they're admitted and why patients get IV steroids instead of oral steroids, because there's real worry about what could be missed here. And so I have to figure the diagnosis out often without these MRI features, and indeed often without the antibody test, because that also takes, a couple of weeks to get where I live. So that's why for me, all of this stuff that I've talked about earlier, who the patient is, how bad their vision is, what's unusual about their particular presentation, these are the things that have to guide my decision making in terms of how aggressively I treat them and whether I am pretty suspicious or not that they have NMO. So here are some more features that might or might not interest you. So this is like a front-on version of the optic nerve. So this is a picture where these are the muscles around the eye. I do this with my patients. I might bore them silly. You might be bored silly right now, but I think it's really helpful sometimes to see what the pictures show us. And in my world, in addition to having pictures of our faces and our families, I think people should have pictures of their eyes and sometimes their MRI scans. So here you see how bright and thick this optic nerve looks relative to this one. And this is a front-on view of how bright it is. These are all tools that your docs will use to go, did I miss something? Am I on the right track here? And sometimes for people who have MOG, they're more inclined to have this sort of bright signal, we call it enhancement, that circles the nerve and extends into the tissues here in the orbit. So that can be a clue. So I really just threw all this at you, and maybe in a good way or a bad way, to talk, to kind of open the discussion and convince you, I hope, that optic neuritis is a common presentation of NMO. And I think I'd be curious to know for how many of you this was your first presentation, and whether or not it was recognized for what it was when you initially presented to physician's care. I've talked about certain features that distinguish neuromyelitis optica spectrum disorder, optic neuritis variants from other causes, but I will also say it's not always that easy. I think there's a lot of overlap. There's overlap in who gets it, how bad the vision is, even in what the MRI scan can show us. So it's sometimes not as easy or black or white as I have kind of necessarily projected in this talk. And I would have to say I've been surprised at times, and it's taught me to be more cautious always. And I'm happy to discuss further how the visual system can help provide insights, not only with respect to how the diagnosis is made, which is, I'm sure, important to us all, but also how we follow folks and maybe give them the information they need to understand how they're doing, because I think it can be really, really stressful when your first presentation of NMO took something really important from you. It might be vision in one eye, vision in both eyes, your ability to walk, or left you with significant pain, and then to lie and wait for the next thing to happen is, I know, very stressful and a source of understandable anxiety. So without further ado, I'm happy to take any questions. And I'll do a time check to see where we are. So we're kind of at the halfway mark. So what I will do here is I'll stop share and maybe look at the chat and look at the questions and the answers. Oh, look at this. Okay, so I'm going to read out things and discuss my answers as complete or incomplete as they may be. So Angela says, I had cloudy vision and a black spot in my vision, but very little pain. It felt more like tension, not pain. I think that's a really good way to say it. I sometimes hear people say it feels like a pressure. And I think that is what often can lead folks to be diagnosed with some sort of headache syndrome. And in fact, if you look at leading causes of misdiagnosis in optic neuritis, it is an overassignment of pain in someone who has good vision. So a person with a headache syndrome may have a lot of pain, indeed very severe pain, pain that makes their eye water and makes their eye red, but their vision will generally be intact. I think the really important point is the severity of the vision loss. And Angela, if you were, your classic typical optic neuritis patient, so Caucasian female, 31 years old, I think it would be easy to mistake that first presentation of optic neuritis as a more typical variant, and that may have affected your care. But if there's any red flags in terms of you weren't that person, or your vision was really severe, or if pain wasn't so prominent, that would have definitely got my attention. But hindsight, as they say, is always 20/20. Tamanika, and I apologize if I mispronounced this, Tamanika, I'm undercaffeinated and barely have a first language. Tamanika says, it was my first presentation and it was declared vertigo. And I'm wondering if that was hiccups, or if it was a sense of dizziness, or if it was part of what we call a brainstem relapse. And the brainstem is like our central control center for a lot of the nerves that we call them the cranial nerves, but certainly nerves that control how our eyes move are sent, they connect to our balance center, the brain, and can give us a sense of imbalance or vertigo. And vertigo is really tricky. So many people have vertigo. I think it's really easy to chalk vertigo up to something else, like a benign positional vertigo or an inner ear pathology, because it's it's something that people who don't have any significant brain disorders will get. But again, if it lasted a long time, things on exam that shouldn't be there, I think it could easily be a first presentation, just as you describe of NMO. So Gabriella says, lots of patients I know with NMO indeed do experience pain with optic neuritis. You're absolutely right, Gabriella, and this may lead to misdiagnosis and initially labeling them with more typical optic neuritis. You are not the first physician who has mentioned lack of pain as an indication of NMO. But I think you really raise an important point, Gabriella. An atypical presentation of a more typical thing. So that would be the optic neuritis that may or may not be related to MS, that occurs and has a really good natural history. And by that, I mean, it's really going to get better by itself. 92% of the time that person will have pain, but 8 to 10% of the time they won't. And I think to Angela's point, sometimes the pain's not very dramatic. I really have to ask the patient, hey, how bad was the pain? Like, did you notice it? And they're so bothered by the vision loss, they don't really put much emphasis on the pain. So I think it's a potential pothole, because I have patients with typical optic neuritis who don't have pain. And then patients with NMO can have pain. And I think this too could lead to a delayed diagnosis. Catalina says, are there any treatments to revert long-term effects in NMO in the eyes, like nystagmus? Nystagmus is really hard to treat. I think this is what would be part of what we call that brainstem presentation, Catalina. So that would be someone who has that central control center in the brainstem with its connections to the cerebellum or balance center. They'll get nystagmus. So nystagmus is an involuntary movement of the eyes that gives you a sense of things jiggling in your vision. It might be to the side, it might be looking straight ahead, it might be up and down or side to side. It's really, really hard because it makes people feel sick and off balance all the time, and it really disables people because they can't do things like even sit up comfortably. In that setting, it's hard to treat. Our acute treatment options, whether we know the diagnosis or not, are still, our go-to is usually high-dose steroids, and that may not help what's called a brainstem relapse. And then if recognized, we could potentially try Plex, like I've mentioned. But I think that if you ask me what people find one of the hardest things to live with, it's just like you're describing, Catalina. It's that jiggly movement in their eyes in the sense of always feeling like you're not steady and about to tip over. Thank you, Tamika. Yeah, side to side. So we would call that horizontal nystagmus usually, where either looking straight ahead or to the side, we'll see a movement where the eyes are like this. And I say to my patients, you know, it's like when your doctor makes you do that finger nose test and you have a hard time hitting your target. The eyes are the same, where they jiggle off target. And it's hard. I find this to be one of the times I feel least effective, because I think that treating the nystagmus and the vertigo is, you can't even help a person sit up comfortably. So I'm sorry you have that, and I hope it's gotten a bit better. Do MOG patients tend to experience pain more commonly than MO? The literature would say yes, and part of that is where the inflammation is. So upwards to like 86 to 90% of MOG patients will have pain, and it may actually predate the vision loss a little bit. So some MOG patients who are prone to recurrent optic neuritis events kind of know when they're going to get that very distinct pain that an optic neuritis event is coming on. So they are a little bit more inclined to get pain than NMO patients for sure. Angela says, I had more pain with uveitis. Oh, absolutely, and Angela. And uveitis is tricky. I could see a lot of pitfalls in your diagnosis because, you know, uveitis refers to, for everybody else on the chat, it's an inflammation in the layers of the back of the eye, and it often presents with blurred vision, light sensitivity. Really, it can be pain depending on what layers are involved. And in the sort of the jelly of the eye, we call the vitreous, there can be inflammation. And I think one of the things that makes pain really bad in that setting is not only just that you've got inflammation of a really sensitive layer of the eye, but that light can provoke the pain, and it's hard to avoid light because you don't want to go around all day with your eyes closed. And then depending on where the uveitis is, it can affect how the pupil works, and so that can be another source of pain. Okay, so I think I've got the chat covered. I hope I didn't miss any questions, and now I'll see if I missed anything on the Q and the A. Does massage help, or would it cause any complications, from someone who prefers to remain anonymous? And I don't blame you. I don't think there's a massage would help. I just, in my experience, and I think that there's a audience of people who know better than me on this. I think that massage can help pain, particularly if it's like musculoskeletal or tension related, and if it worked, great. I think it probably cannot help, but I haven't had much experience or luck myself in relying on massage to help the pain of optic neuritis. And it has to do with, I think, the nature of what's inflamed, or uveitis, I think, you know, to some of the earlier points. And I'm going to come back to Liliana's question, and it's linked to Angela's question. Angela says, I had uveitis a couple of years ago. The ophthalmologist said that's something that's seen in MS, but not neuromyelitis optica spectrum disorder. Is that correct, or could my uveitis have been associated with neuromyelitis optica? Sorry, it has nothing to do with optic neuritis. No, absolutely. I have seen uveitis in NMO, and I've seen uveitis in MS, and that uveitis is a little bit more upfront inflammation. So it's not where the eye leaves the back, where the optic nerve, that USB cable leaves the back of the eye. It's in the layers of the back of the eye. And I think that, kind of like I said, you know, the back of the eye is the front of the brain. And I think that the uveal tract and those layers could become involved. I think personally that it's probably underrecognized in MS. And if I were to, by extension, think more broadly, probably underestimated in NMO, because people can have uveitis and actually, believe it or not, Angela, not know they have it. Because if it's mild, it might just cause a bit of blur and not much pain at all. So I have found in the last 10 years of my career, I've recognized more uveitis as a cause of visual symptoms in my MS patients, causing me to realize I probably underrecognized it in that setting. And I would venture to guess it could be underrecognized in NMO as well. And then Liliana says, what about perioptic neuritis? So That's actually a really important question too, because the perioptic neuritis is something that we think about as being more commonly seen in the setting of MOG optic neuritis. And so the perioptic neuritis is typically supposed to mean that there's inflammation around the sheath or involving the sheath. So it's in a peri-distribution of the optic nerve. And so what you look at is when you look at the nerve sort of front on in an MRI, you'll see like a bright ring around the nerve. It is not specific for NMO. I see it in a lot of different conditions, but when I do see what we call perineural enhancement, so that ring around the nerve, in a person presenting with optic neuritis, my first thought actually is, hey, could this be, MOG optic neuritis? But then I have to remember that there's this whole category of orbital disease. So that's disease that's in the structures around the eye itself. And perineuritis can be just part of that. And a lot of those syndromes, we don't ever really find a name for them. We call them idiopathic. There's other conditions in the body, like lupus and sarcoidosis. I don't know if you've heard of them, but I think a lot of NMO patients have, because these are things that get bantered about in terms of what your doctor thinks about what you might have when they're less convinced you have MS. And they're in the differential, or what we call the list of possibilities for NMO. You can have perineuritis, inflammation of the optic nerve sheath and around the optic nerve, in a lot of different settings. And I actually think that could lead to a delayed diagnosis, particularly for somebody with a MOG optic neuritis presentation. And I wouldn't take it off the table actually as a way that someone with NMO could present either, anyway, any more than I would think that uveitis would be off limits. So I think I've talked too much and maybe talked you all out. If that's, yep, oh, here we go. There's Angela, thank you. I hope you found it helpful. And I do, again, apologize. Despite my very best efforts, as I listen to myself, I sound somewhat robotic, and that's just, I think, too many decades of talking like a robot about this. But I'm very open to questions to provide any kind of clarity I can about what the optic nerve means in terms of your well-being and how it can be affected in NMO. And thank you for the kind comments. Okay, I'll check the Q&A. Oh, Q&A. Open to. I think I got the Q&A box. I'll see answered, dismissed. Recurrence of flares, it's from Catalina. Okay. So that's a really important question, because I think, and you know, that in NMO, every relapse matters. So untreated or perhaps misdiagnosed NMO, or NMO that's initially mistaken for MS, could easily flare, because if you don't have a person on the right immunosuppressive therapy, I would predict they're going to get more events. Sometimes it's actually not that easy to distinguish a flare in someone with NMO, because if they have really bad vision in their eye, some of our tests are not really good at picking up new onset problems. So that's where I have to really rely on my patient, who knows himself, herself better than anyone. What's the quality of the pain? What's the change in vision? Because some of my tests stop being sensitive if the vision loss is severe. I treat all relapses, mild or severe, obviously, related to NMO, with high-dose corticosteroids, and I'm having a lower and lower threshold to use this plex therapy, that washing therapy, where the catheter is put in a central vein. And the reason I do that is I think vision is so essential, and I want to hold on to whatever that person has and regain whatever I can that they may have lost, recognizing that if I'm too late doing that, or I allow too many flares to go untreated, I'm not going to be successful. Flares, we know, are a little bit more common in MOG patients, maybe more likely to get recurrence, but MOG patients don't suffer the same hit. Like they don't pay the same toll each time they have an optic neuritis patient, typically, each time they have an optic neuritis event, typically, there actually are some cases of MOG that very closely resemble the course of NMO. So I would say that the flares often depend on the patient. So I have patients who've had preserved optic nerve, function. They've never had an optic neuritis event, but they had a horrible transverse myelitis event. And I follow those patients too because I want to make sure that we keep what they've got in terms of not only their motor function and how their arms and legs move, but also how they see. But the really tricky bit with NMO is, every relapse matters, and the whole goal of treatment needs to be in like squashing relapses, because every relapse takes something from the patient, or from the person, I should say. And I think that if a person is still having flares or relapses, then consideration needs to be given to, are they on the right therapy? Is it enough for them? There are people who can take milder drugs than others and not have relapses or flares. But then there are people that you've really you gotta do whatever you can to reduce or eliminate flares altogether if possible. And I think that's a very, very important point. Flares or relapses of optic neuritis definitely are damaging to patients with NMO. And I think that should be the whole goal of their treatment, is to prevent these from happening, because you'll probably experience, certainly my colleagues who work with more of the non-visual presentations of NMO, they'll say, mild relapses definitely occur, but I have like a bias towards seeing people with vision loss, and I don't consider any vision loss in an NMO patient mild, and I don't treat it lightly. I take it very seriously because I don't know how much more they can lose. And that's just my own personal philosophy. And I hope it's one that you've heard echoed by some of your other docs. And I think that's a big difference between MOG optic neuritis and NMO optic neuritis, and MS optic neuritis and NMO optic neuritis. The flares or the relapse take so much more from the patient if they have NMO. Tamanika says, is it odd that I don't receive IVIG every 4 weeks with optic neuritis flares, and would PLEX be an option? That's a really tough question. And would PLEX be an option to possibly stop optic neuritis? Really tough question. And I can say that there's not a clear answer that you'll find in the literature. So that's important. That's my disclaimer, but I'm going to tell you my own personal philosophy. So I realize a bias in my practice has been, if someone comes in with bilateral vision loss, and we all know that plenty of people with NMO can come in blind in both eyes, that's obviously going to get everyone's attention. And, a person will often be admitted to hospital, they'll get IV solumedrol, and they might get PLEX in the right setting, but you need to be in a place where you can access it and where people think of it. Because PLEX is not a small thing to arrange for someone. There's risks around PLEX. You could actually give them a blood infection. You're, sticking a big catheter in a major vein. But I'm having a lower and lower threshold despite those risks. And I'm actually having a lower threshold to treat people who present with just monocular or one eye involvement, because I've seen it improve things when steroids did not. So what I would say is, my personal viewpoint is, especially if I know someone has NMO, I have a very, very low threshold for PLEX, and I put in my notes about my patients, if this person presents to the emergency room with complaints of vision loss, admission, steroids, and PLEX need to be considered early in the course of their treatment. And I hope that allows them almost like a passport through the emergency room, so they don't have to re-explain themselves every time and re-explain what their diagnosis means to their vision. So I hope that helped. But that is it's a controversial question, and I probably gave a controversial answer, but it's how I look at it. Thank you. And what I could do is maybe type some of the answers and we can stop the recording. I know I've probably gone past time. So I can continue if we stop the recording, just answering questions. Does that work, Samara? I'm very happy to do that.
Oh, that's so nice of you. Yeah,
Yeah, yeah,
I will go ahead and stop recording, and
yeah.
you can definitely go ahead and do what you need to do. If you don't mind, can you just hit the or make me a host again?
Oh, for sure. Yeah, let me do that. So chat, share screen. Oops, you don't want that. Okay. I think I
If you go to
go
panelists
panelists. Oh, I look
under
like
part,
a participants. Okay,
yeah,
hold on. Oh yeah,
participants,
yeah,
and
here
then
we go.
yep, and then you can make
Invite.
me.
It just
Um,
says invite.
when you click it, is there a bar that comes up on the right?
Okay, let's try that. Yeah, here we go. So mute more, make host. Thank you for the change host for the
Yeah,
guidance.
perfect. No problem at all. I just want to
Yeah,
get
and
this.
I'll answer some of these questions. I think a really important one was asked, and I should say IVIG I haven't used as much in NMO, but it has been demonstrated in studies, for example, with MOG to be a good maintenance therapy. I actually haven't used it in that setting, and I think it's been used a little bit more in kids, but I think it's an interesting question. How about this? Not related to optic neuritis, what's your take on mental health? I think that's a really, really important question, but I think that the ill effects of NMO on mental health are probably under-recognized. And I don't know if that has as much to do with the patient not necessarily having a voice or feeling they do, because of aspects of their life, where they're from, their age, their sense of power in the circumstance, or if it's because the physical effects of NMO can be so daunting. But I think that the idea of having to live in fear of a next relapse and what it might mean is probably underappreciated in terms of how that unravels the mental wellness of the patient. And also the journey that many patients take, where it took a while to get diagnosed and then they've been left with a lot of loss. I think, and I've often likened the sort of the psychological effects as a form of post-traumatic stress disorder for many people, but I cannot speak to this with nearly the same clarity or authenticity as many of the people on this call. But I think it's really underappreciated. I'm struck by that a lot. Um, Natasha asks, here's my long-winded question. Well, you're in good company. Nothing I say is anything but long-winded, Natasha. Would you have any other advocacy tips for people concerned with their first presentation as being misrepresented, or who've been seeking a diagnosis unsuccessfully for a long period of time? In short, as a clinician, what keywords or approach would make you or your peers consider NMO? Natasha Navigator, MS Society of Canada, perfect. Firstly, who my patient is. So again, personal bias, I'll just sort of say it. I feel like many of my NMO patients come from backgrounds where they don't necessarily feel like they have a voice or they can complain. They don't get a lot of time off work. They don't have any kind of safety net in terms of their job. They might be the primary caretaker, the primary breadwinner. And I feel that we need to have a way better understanding of what should be red flags. For example, I can use optic neuritis as one, but the hiccups thing. I mean, so many NMO patients, present with intractable hiccups, the kind that make them retch. And I think getting information to non-neurologists about the diagnosis of NMO is key. I think really providing education to ophthalmologists about red flags for optic neuritis so that NMO patients are lost in the kind of lake of optic neuritis all comers and have to, really lose significant amounts of vision before their problem is recognized. I think as well, we need to help people have a voice. And I think the Samara Foundation is an excellent example of, and this webinar series, is an excellent example of shining light. And I'm, onto the darkness, not only of NMO, but of recognition of NMO. And so I think if I had to contemplate this, I would probably come up with better ideas. But I think our work has just begun on that front. I think there's so much we need to do because advocacy is key to spreading important messaging. And then all of that is key to earlier diagnosis. So Catalina says she takes rituximab. I think it's good. Catalina, a lot of people do very well with rituximab. And prior to the newer therapies, it's been a mainstay of therapy, for example, for many patients I look after. So if you're doing well on that and not having relapses, obviously mild or severe, I think that's very reassuring and you shouldn't worry. Good. I'm glad you're doing well. I think, do treatments have an effect on the quality of vision? I think all patients with optic neuritis are left with problems in their vision, great or small, depending on how severe the problem was. And our whole idea needs to be to literally control the damage. And so I think definitely getting the message to ophthalmologists to be more inclined to treat as opposed to just watch, because they can watch typical optic neuritis because we know that steroids in the setting of typical optic neuritis. So that's your patient who may not get a diagnosis of anything and had a sporadic or one-time thing or MS. They still have a really good natural history of just getting better with no steroids at all. But we can't be complacent with people who have those red flags who may go on to get NMO, because those folks are going to have very poor recovery and be more inclined to have a relapse or a flare of their optic neuritis if they're left untreated. Let's see. One new message here. I don't know. I hope I haven't. Oh, here we go. Do you think there's a way to get an ophthalmologist and optometrist to understand not to immediately tell a patient that presents that they may have MS? I was talked to too many people have told that. I was told for years, MS, MS, MS. Yeah, I think it's a really important point. And I think the problem with, the problem, I don't mean this as a problem. I don't consider ophthalmologist a problem or optometrist. The problem is in pattern recognition, which is we recognize the patterns we see the most. And, if you look at some studies, only about 10% of optic neuritis patients may have MOG or NMO combined. Like they may have either MOG or NMO. So in high volume settings, any doctor, myself included, we often default to what we see the most and know the best. And I think that is important because a lot of people presenting with optic neuritis are mistakenly diagnosed with MS. So I personally feel that's a call to action for people like me to give a version of this talk to primary treating ophthalmologists who are often the first point of care, or optometrists for people presenting with vision loss, because I think some of those red flags that I talked about are not so commonly known. And if they're not recognized, people will be mistakenly interpreted as having MS or something else, and they will go undertreated for NMO. So your point's really, really important. And unfortunately, very sort of relevant, because it's certainly a problem that I see for people presenting with optic neuritis, and that's their initial sort of encounter with a healthcare professional on their sort of journey with NMO. Okay. Well, I love talking about anything to do with the eyes and the brain and the spinal cord and the peripheral nervous system. I love talking about optic neuritis. I learn a lot from my patients. A lot of the lessons that I have tried to impart have been hard-won from their experiences. So I'd be happy at any point to revisit this topic, and it's really been a pleasure to meet with you today and hear your great questions. Thank you.